I'm excited to tell you that this webinar is actually a launch of a Creating Youth-Centered Care Learning Community. This is an opportunity for us to come together to connect, explore, share ideas about what works as we work to make healthcare better for young people 10 to 25. We're going to do this through monthly interactive webinar trainings and discussion forums. So the key word here is interactive. This really is an opportunity for you and others to come together with your questions, your challenges, successes, experiences, and lessons learned. Time to listen and talk with others who have tried things out, done this work for a long time, or who have just started. So welcome to this learning community. So just to give you a bit of a housekeeping and connect you to this WebEx platform, and let's go backwards here for a minute. There we go. There's two things you can do with your screen during this webinar. First, you can toggle the participant section at the very top. You can see who's here. And just for a quick note, when you see Kristen Teipel, that's actually Rena Large. And I, as Kristen Teipel, am actually Kristen Granquist. So just the joys, don't ask, it's the joys of being on WebEx at the University of Minnesota. The other thing you can do is chat, and we do encourage you to do that today. In the box at the bottom, just type in your questions, your comments, if you need help, things like that. Choose the all participants and then send off your message. So while you're here today, we do encourage you to participate, and that's through two ways. Chat in the chat box, type in your questions and your thoughts throughout. And then you're on a phone line. So we'll stop 2 times during the presentation for discussion breaks. We'll answer the questions that you put in the chat box, get reactions, thoughts, things like that. So just as a reminder, you are muted. If you'd like to speak, press #6, wait for a second, and then start to talk. And then feel free to mute yourself again with *6. All right. Well, our guide today is Dr. Wendy Davis, and she's a colleague with me and Rena at the Adolescent and Young Adult Health National Resource Center. She's a professor of pediatrics at the Lerner College of Medicine in the University of Vermont, and she's the associate director of the National Improvement Partnership Network. And if you don't know what NIPN is, I'd encourage you to Google it. It's a great organization. While practicing general pediatrics for 20 years in Burlington, Vermont, Wendy was a founding member of the Vermont Child Health Improvement Program, or VCHIP. This is a population-based maternal child health services research and quality improvement program. And Wendy participated and served as a faculty for numerous maternal child health quality improvement projects. Between 2007 and 2013, she filled many roles at the Vermont Department of Health, including service as the director of the Maternal Child Health Program and Vermont's Commissioner of Health. She also served in the state and district leadership roles for the American Academy of Pediatrics, for which she is currently the District 1 chairperson. Wow. As you can hear, Wendy's a highly qualified person to walk us through this healthcare system today. So welcome to Wendy.
Thank you very much, Kristen. Thank you for that lovely introduction. Good afternoon, everyone, or wherever you are across the time zones. It's really a pleasure to be with you today to try and provide an overview of the healthcare system for adolescents and young adults. And I just want to say that I have no relevant financial or commercial relationships that might pose a conflict of interest. In talking about this subject, I will not be discussing the unlabeled use of a commercial product, but I do very much want to acknowledge a couple of things. One is the context here, and as you will shortly see, when I speak about the system of care for adolescents and young adults, you'll note that there's going to be really more of a heavy focus on the adolescent part of that system, and I'll explain why in a few minutes, but also the fact that even that system has its origins in the evolution of the pediatric healthcare delivery system, and I'm going to walk you through a little bit of that history shortly. I also want to thank very much some colleagues. Kristen acknowledged our colleagues around the country in the National Adolescent and Young Adult Health Information Center and the National Resource Center, and in participating in this project, I have learned so much from them about this subject, and they have really provided wonderful leadership and a lot of guidance, and some of the resources that you'll see today, and I encourage you to visit the Information Center webpage if you haven't done that recently, and it is actually undergoing an upgrade, so please go back and visit often. You will see new resources posted there frequently. And then also my colleague, Dr. Richard, or Mort as he is known, Wasserman, who is a colleague in pediatrics here at the University of Vermont, and Mort has had a long interest in the evolution of the healthcare system and some of the more recent developments, and again provided some guidance and resources for this talk. I do have some learning objectives for you today. I hope by the end of our time together that you'll be able to define and at least briefly describe, if not the whole picture, a few of the key milestones in the history of health reform and healthcare delivery for adolescents and young adults. And you may hear me slip and refer to them as AYAs as we go through this presentation. Hopefully that's a familiar term for this audience. As I mentioned, I will start with the role of the child health and welfare movement, which is really where a lot of this work began in the late 19th and early 20th century. And we're going to focus on primary care and preventive services, but I will talk a little bit about acute care and care for chronic illness in this population as well. And then we'll move on to talking a little bit about the current and hopefully some future models of care delivery and payment reform. And of course, we're in quite a state of flux with regard to that bullet, but hopefully some of the principles that you'll see today will be things that you can tuck away as we watch our system evolve over the coming months. And then finally, we'll end with talking about some potential strategies, hopefully partners, and my guess is that many of you already have these partners in your communities, but maybe we'll introduce you to some novel partners. And then really a bit of a focus on incentives when we think about how to improve access to and the quality of preventive service delivery for adolescents and young adults. So let me start by reminding you of some of the milestones in the evolution of our healthcare system and health reform activities. And as I said, this is really grounded in where the pediatric healthcare system started in the late 19th and early 20th century. I think the most important thing to remind you of is that health reform is not new. We've been at this for well over a century, in fact. Sometimes I think about that and think, gosh, it's interesting to go back and look at some of these earlier proposals and models and see how very similar they are to what we've come to in the era of the Affordable Care Act. I refuse to be depressed by that notion. I think it just means that we're on the right track, and sometimes a good idea takes a few different fits and starts to really get going and get traction. But this movement really came out of a child health and welfare movement that had evolved over the late 1800s. And those of you familiar with that history will know that that is really when child welfare work occurred largely through philanthropy and often at the local level. And like other social reform movements in our country at the time, this particular movement gained some momentum in the political climate of the early 1900s with the establishment of some effective national organizations and the recognition of the problems of childhood at the federal level. In 1909, the first in a series of White House conferences on children and youth was conducted, and that meeting eventually led to activities that resulted in legislation that established the United States Children's Bureau in 1912. And in those early days, there was really a focus on infant mortality reduction. Again, a theme I think you'll see through this history is that the early foci were on infants and young children, perhaps the most vulnerable among our pediatric and adolescent population, but as time went on, that movement expanded, and we'll talk about that. In 1921, some of these efforts actually ended up being codified in federal legislation entitled the Shepard-Towner Act, and this included some funding to establish maternal and child health centers and services. So again, really the beginning of some of the activities that we now see embedded in the Maternal and Child Health Bureau. But unfortunately, by 1929, when this act needed to be reauthorized, they could not garner adequate support for reauthorization. And interestingly, one of the organizations that opposed this kind of legislation was the American Medical Association. And there was really, I think, among the medical community at that time, a bit of a fear about legislation and regulation of health care. Again, that may sound familiar to you for today. And the AMA has taken different positions on national health insurance over the years. But unfortunately, at the time, they did oppose the reauthorization of this act. It had a great side benefit, however, because the reauthorization was supported by the pediatricians in the AMA. There was actually a pediatric section of that organization. They supported the reauthorization, and when it was not reauthorized, they broke away from the AMA and established their own organization, the American Academy of Pediatrics, which was founded in 1930. So although there was a bit of a conflict and not a good outcome for children at the time, it really was the genesis of the AAP, and that was certainly a good thing. So moving ahead to 1935, there had been in the ensuing years a lot of activity, again, moving us towards national health insurance, but this was really being conducted in the broader context of overall social reform. And so in 1935, there was an actual proposal for national health insurance which had many of the elements of what we see in our legislation today. But there was concern, and this was in the administration of Franklin Roosevelt, that support for the health reform piece of this legislation might derail the entire Social Security Act, and that was seen as an overriding concern. And so, once again, while the Social Security Act passed, we were unable to garner adequate support for major national health insurance reform. However, again, a happy side note here, some of the maternal and child health activities that had been supported by the Shepard-Towner Act were supported again now by grants that came out of the Social Security Act. So a little bit of a reestablishment of a focus on infants, young children, and their families. And then in 1939, the Federal Security Agency was established. That was the forerunner of some organizations that we know by different names today, but this was an agency that included all of the departments that oversaw national activities related to health, welfare, and social insurance. And at the time included things like the Social Security Board, the U.S. Public Health Service was part of this entity, and the Food and Drug Administration was part of it at the time. And again, fast forwarding to 1953, the Federal Security Agency was actually the precursor to the U.S. Department of Health, Education, and Welfare. And so then in the late 1950s and early 1960s, the major activity, and even somewhat in the post-World War II period, was laying the groundwork for the enactment of Medicare and Medicaid as entitlement programs. This was an era when there was an increasing focus on employer-based coverage. Some private health insurance type plans had been using what was referred to as the experience rating to begin to set premiums for their beneficiaries. So again, the forerunner of what we very much see embedded in our health insurance industry today. But it was very clear at the time that this kind of coverage was much less accessible. There were many barriers in access to coverage for vulnerable populations like our retired population, the elderly, and the disabled. And so this really led to the establishment in 1965 under Lyndon Baines Johnson of Medicare and Medicaid as incorporated under the Social Security Act. And just a few years later, we see the establishment of the Early Periodic Screening, Diagnosis, and Treatment, or EPSDT program, again, embedded in that legislation. And it's always interesting to me to think back about the fact that this program was actually enacted in recognition of the high rates of untreated childhood illness that were making military draftees ineligible to actually serve our country. So it was great because EPSDT essentially became the benefit package for children who were eligible for Medicaid and became a fairly comprehensive benefit package. But, you know, once again, we see that even then, this was not done just in the best interest of covering our child health population and our most vulnerable citizens, but in fact because we needed to conscript our young adults into military service. But again, we'll take the silver lining that it turned into a good program for children and families. In the 1970s, we saw a rapid growth in health care costs, and again, there were multiple national health insurance proposals put forth, but with the rapidly accelerating costs, there was a great focus on cost containment even then, and this was also an era of increasing healthcare regulations. So programs like Certificate of Need programs and hospital regulatory programs really came into being and very visible during this particular era. And in 1979, the Department of Health, Education, and Welfare actually then evolved into our now Department of Health and Human Services, and at the time, the educational services that had been covered under the previous entity broke off and were now housed under the new Federal Department of Education. In the 1980s, we saw a gradual expansion of Medicaid coverage, particularly, again, with a focus on infants, young children, and pregnant women. So gradual expansion, but our adolescents and certainly young adults, unless they were pregnant women, were still not in the forefront of people's minds in terms of who needed access to care and health insurance coverage. In the 1990s, this type of expansion continued, and now with a little bit more of a focus on older children and adolescents, so the 6 to 18-year-old age group. And hopefully many of you may remember Clinton's Health Security Act, which was really the next wave of a very comprehensive health reform package and a step on the pathway to national health insurance. It was fraught with political conflict and eventually did not make its way to see the light of day as legislation that passed, but again, contained a lot of the underpinnings of what we eventually saw in the Patient Protection and Affordable Care Act, and certainly pulled together a lot of the work that had preceded it in other national health insurance proposals. Also in the 90s, we saw some flexibility emerge in the Medicaid program, and states could obtain waivers that would allow demonstration programs to expand coverage. And so many states took advantage of this opportunity to expand coverage and also to increase the benefit package of services identified under EPSDT to a more comprehensive benefit package for children and youth. And in 1997, much of this was codified in the State Children's Health Insurance Program, or SCHIP. So I'm going to, again, fast forward us a little bit. A lot of attention to this through the 90s and the early 2000s, but all culminating in 2010. And at the time, I think many of us thought, wow, we've really gotten almost the last mile, if not the last mile, to the path to meaningful health care reform in the Patient Protection and Affordable Care Act. And of course, you're all familiar with the health insurance coverage reforms, and particularly those that affected the adolescent and young adult population. So for example, the coverage of selected preventive services with no out-of-pocket cost was really seen as a boon to encouraging people to take advantage of preventive care delivery. Those states that chose to expand their Medicaid programs also had, in many instances, a very positive impact on providing insurance coverage, if not necessarily access, but coverage at least for adolescents and young adults. And certainly the extension of dependent coverage by private insurers to young adults up to the age of 26 years under their parents' plans and coverage. All of these were seen as a boon to encouraging the participation of adolescents and probably most particularly young adults in the healthcare system, and in particular to access preventive care services. But it's important to note the healthcare delivery system reforms that also were embedded in the Affordable Care Act. And in particular, some that we'll talk about were great incentives and support for testing new models of care delivery. I'll talk about some of those in a moment. We saw a lot of investment in resources to improve the systems of care, and part of the work that we do here at the Vermont Child Health Improvement Program and in our network across the country, now we're in roughly 25 states with similar organizations in the National Improvement Partnership Network, is to really provide a sustainable infrastructure for folks working in the healthcare industry, in healthcare delivery settings, and increasingly in public health and community settings to try and improve the systems of care. And if folks are interested in what we do at our organizations, I'm happy to talk about that with you offline or during our discussion period. And certainly a really major development under the ACA in terms of delivery system reform was very significant attention to payment reform. And if I had to characterize it at a very high level, I would say we were definitely seeing a continued shift from what had been a volume-based system of payment for care to a value-based system of payment for care, and I'll talk about what that means a little more in detail. I do want to mention a couple of developments in the history of medical education and how they affected the emergence of an adolescent health care delivery system. If we go back to the 1960s, if you think about it, that's really the decade when the baby boom generation, I count myself among that group, we were reaching our late school age and teens in some instances. And what this drove in our healthcare system, and perhaps most particularly in academic medical centers, large public hospitals and health systems at the time, were the emergence of separate adolescent clinics and inpatient wards as a recognition that this was a population group that really deserved some special attention and care that needed to look a little bit different from how we were providing care to infants and young children. And then in the late 1960s, again, primarily in academic medicine, we began to see a coalescence around different topic areas, sort of discrete areas of focus within ambulatory or general pediatrics. And very specifically, in 1968 was the founding of the Society for Adolescent Medicine, now the Society for Adolescent Health and Medicine. And really this represented, again, the coalescing of a group of general pediatricians who really had an interest in honing their skills in providing care with a very special expertise for primarily adolescents at the time, but depending on how you defined the age of that group, we certainly bled into the young adult population as well. Adolescent health care was also an early focus, again, back in the 60s and 70s for clinical research and fellowship training. And then at about the same time, there was also great interest in behavioral and developmental pediatrics, which emerged as a separate specialty as well. And with what was then described as the, quote, biosocial focus of this discipline, while much of the attention was on developmental screening and services for infants and young children, there was also the recognition that behavioral and psychosocial issues for adolescents and young adults, again, deserved special research, expertise, and treatment and care for that population. So with that, as a very quick walk through some of the milestones, where did we get to with our United States healthcare system? And I use that term lightly because, as you may see from the bullets on this slide, there are parts of it that sometimes function like a system and then parts of it that perhaps not so well. And in contrast to many other countries, you all know that in the U.S. we have no central governing agency. We have a lot of federal and national agencies and organizations, but really no one single entity that covers all of the different players. And unfortunately, there's often not a lot of coordination among those many organizations and entities. In the U.S., government is really a subsidiary to the private sector and subsidizes health care, but very different relationship than many other developed Western nations. We have multiple layers and payers, and really we have a very different balance of power in this country in terms of who drives and who steers the bus, really, in our healthcare system. Our access is based on insurance coverage, and again, as I mentioned or alluded to earlier, having insurance company coverage doesn't necessarily guarantee you access, unfortunately. Those can be two very separate aspects of seeking health care, and particularly for our adolescent and young adult population. Unfortunately, our system to date has somewhat been characterized by relatively high cost, unequal access, a lot of health care access disparities in our country, and relatively average outcomes, and I'll show you some data on that in the next slide. We've had a focus on acute care and curative care as opposed to preventive care, and we're getting better certainly at grappling with and providing good care at the end of life, but that had not traditionally been the focus in the U.S. system. We've always placed a high investment in our research, in innovation and developing new technology, and I think it's fair to characterize our system as one which reflects conflict at times between market justice and social justice, and unfortunately, historically, oftentimes it's been the market and economic justice factors that have won out over social justice. We have seemed to strive for integration in our system, and there's certainly been an increasing focus on accountability by healthcare professionals, by hospitals and health systems, and to some extent we've had a drive towards, even if we haven't necessarily fully supported, the idea that coordination of many of the subsystems of care should be conducted within our primary healthcare delivery system. And finally, unfortunately, probably as much if not more than most, again, Western and developed nations, we see our healthcare practice and professionals influenced greatly by the liability and legal risks that they undertake in practicing medicine. So this is that international comparison, and you may not be able to see this terribly well, but it's basically a comparison of the U.S. system and shows us to be the most expensive in the world, but also shows how we underperform relative to the other countries on most of the dimensions of our performance. And again, since it's small, I can tell you the other nations are countries like Australia, Canada, France, Germany, the Netherlands, New Zealand, Norway, Sweden, Switzerland, the United Kingdom. And overall, we rank last among this group if you take all of these attributes in total. The UK is first and Switzerland is a close second. And we have made significant strides, I think particularly in the wake of the ACA, in adopting certainly health information technology and undertaking some of the payment and delivery system reforms that other countries had in place before we did. And if we were able to continue to fully flesh out the promise of the Affordable Care Act, we could probably continue to make strides in our efficiency and effectiveness of our healthcare system. But currently, as of this table, and this is from a study that the Commonwealth Fund looks at periodically every few years, and back during this time, which was 2010-2011, our best features were in overall quality, but we ranked number 5 in effectiveness of care. Number 5 in overall quality, number 3 in effectiveness of care, number 4 in patient-centered care. And then you can see on things like cost-related access and efficiency and equity and healthy lives, we were dead last, all leading up to that overall rating of number 11 in this group. So, you know, high costs, not the outcomes that we would have liked to have seen. And so what is it that we've been doing about that? Excuse me. Well, this slide shows you some of the delivery system reform and in particular payment reform models, again, going back a little bit in history. So back in the 1980s, we were really operating primarily as a fee-for-service system, meaning a service was performed or provided and healthcare professionals and systems were paid simply based on that service delivery, in a sense similar to what we see in industry in what's described as piecework. So basically money changing hands for an identifiable service. Remember, though, I said that and the decade that preceded it was really the era when we began to see healthcare costs skyrocket, in part because there was really no cap on the system. There were very few controls, and new technology was emerging that, if we were going to make it available to all, was very expensive. And so in the 1990s, the solution to this issue was to develop systems of managed care, or capitation systems, where health professionals served as what we called gatekeepers, and we were paid a certain amount per patient, simply providing whatever care that patient needed. So no longer thinking about this as piecework, and in fact, if you think about it, providers were incentivized to keep patients out of the office, to keep them away from specialty referrals, for example, anything to keep the costs down. There was still somewhat of a focus on maintaining health, although our measurement systems weren't nearly as refined as they are now. And so that system we went through in the 90s. We evolved in the early 2000s to those systems really healthcare professionals finding the need to sort themselves into entities like networks. So you had independent practice associations and provider and hospital organizations. So people coming together trying to take advantage of economies of scale and really, again, sort of a next iteration of trying to beat the payment system as it existed at the time. Not necessarily a bad thing, but again, not really thinking about how were we going to trade off access and quality for cost back in that era. And around, the end of that decade and into this decade, we saw these kinds of organizations and networks maturing, becoming more sophisticated in how they were negotiating payment and also what benchmarks they were being measured upon. And then again, with the passage of the Affordable Care Act, this concept has really matured to where we're now talking about strictly value-based payments. So no longer are we paying by volume. I don't get paid anymore for seeing 10 children with upper respiratory infections in the office than I do simply for identifying them on my panel of patients. And so this really has moved us to a system where we have to be thinking about the quality of the care that we're delivering and how to measure that. And in particular, many of you may be working in states where you're seeing organizations or entities like Accountable Care organizations or Accountable Health Neighborhoods evolve. These are really large systems where, again, the providers, the hospitals, the others in the mix have gotten together and said, we will provide health care for a fixed amount, we will meet quality benchmarks, and if we're able to do that and meet the benchmarks, any savings that accrue from that sort of system will come back to us for reinvestment in continuous improvement in our system of care. And I've given you a link here to some videos that do a nice job of describing some of these delivery and payment system reforms. But the bottom line is it's extremely complicated, and this is going to come into play when we start talking about incentives, because our role in thinking about how to support improvement in the delivery of adolescent and young adult health care, I think, is to think together about what is our part in this system, how can we support this very rapidly changing and dynamic evolution of how care is delivered, what are the incentives that we can identify, not only for the health professionals, but for the patients and for community organizations to say we're going to get in this game together and really try to work on this and collaborate to result in improvement in care. So I want to talk a little bit about what some of the current and future models of care delivery and payment reform seem like they're beginning to look like. And I do want to just say at the outset that, I want to remind you that we're really talking primarily today about primary and preventive care. That's a topic that in and of itself has had a historical evolution and really an increasingly refined definition if we go back 40 or 50 years or so. Pediatricians were among the first to really try to define what primary and preventive care was. That's always been a core concept in pediatrics. And so over the years, people have acknowledged elements like the fact that it's first contact medicine. So it's often the first door that a child and family or a youth and family enter for provision of routine care. And people who provide that care assume a longitudinal responsibility for those patients and often serve as someone who integrates or coordinates care throughout the rest of the system for those patients. As time went on, some additional attributes to this type of care included making sure that the care was comprehensive, so covering not only preventive services, but also thinking about the availability of acute care and care for chronic illness. Again, the coordination piece was huge. And as we moved into the 90s and into then the early part of the 21st century, people became much more aware and attentive to community orientation and the engagement of community partners in care delivery. The Institute of Medicine in the mid-90s talked about the provision of integrated, accessible health care services by clinicians accountable for addressing a large majority of personal health care needs, developing a sustained partnership with patients, and practicing in the context of the family and community. So really, I think, a very nice definition of what this care should look like. And the American Academy of Pediatrics for decades now has described the medical home concept, and that's one in which care that's provided is accessible, continuous, comprehensive, family-centered, coordinated, compassionate, and culturally effective. So where do we generally find care, this type of care, happening for the pediatric and adolescent population? Well, primarily still in community practices. Some still are independent and privately owned, but those are becoming more rare, and more we see these types of practices being purchased and owned and run by larger healthcare and hospital systems. And again, it's those economies of scale, particularly with the advent of new technology, which is really out of reach for the smaller independent practices, and that's really one of the economic factors that's been driving this evolution. Federally qualified health centers provide a lot of care to adolescents and young adults. Some clinics that provide this care are strictly hospital-based, and then increasingly for this population, particularly for adolescents and school-aged children, care that's delivered in school-based clinics. So going to where we know the patients will be spending a lot of time as opposed to bringing patients for short periods of time into our offices. I do want to point out that pediatricians and obviously family physicians provide a lot of pediatric primary care in the U.S., but pediatricians as the providers of primary care is a somewhat a phenomenon that's somewhat peculiar to the United States. And again, if we look in most of the Western European nations, for example, pediatricians provide much more of what is described as specialty care, and primary care is provided by a number of different types of generalist practitioners. General pediatricians do tend to dominate the provision of primary care to the pediatric population, especially for young children. They tend to provide on the order of 75% of that type of care for young children, and this slide simply shows that that's the line at the top, the blue diamonds, and showing what percent of care is provided by pediatric generalists versus pediatric specialists, and then non-pediatric generalists such as family physicians who provide a much smaller proportion of care to young children. But if we look at the adolescent population, we see that that does drop. So pediatricians still providing about 50% of care to adolescents, but now the non-pediatric generalists and even specialists are providing much more, a higher proportion of care to adolescents, and that probably reflects not only the age difference, but also the focus on chronic illness care in that older age group. This is also a good place to just point out that most primary care pediatricians these days are, as I alluded to before, are employed by others. So it's been pretty stable at roughly 70% over the past several years, and we know this by from surveys that are conducted by the American Academy of Pediatrics periodically to understand where the pediatric workforce is in terms of the kind of care that they're providing. So at a very high level, if we think about adolescent and young adult health care delivery, for adolescents, we see a system that has a pretty well-established financial underpinning. There's an identifiable organizational structure and healthcare professionals that's largely office-based, as I just mentioned. There is a focus on preventive services for which there is some evidence in the literature, but also acute care and chronic illness care are delivered. And parents still play a role in the care of many, particularly young adolescents, middle adolescents, because of their legal status. And when we talk about the system for young adults, it looks quite different. The financial system has been emerging, unfortunately, with our current political climate. It may be somewhat in flux, but there really is not the same kind of identifiable structure or group of healthcare professionals devoted to providing care for this age group. Much less of a focus on preventive care, although there is some evidence that supports the kinds of guidelines for preventive screenings and referral and treatment for young adults. And of course, the family and legal context changes when young adults reach the age of majority. Content of care, as I said, is not only acute care, but also chronic illness care and well child care, but traditionally acute care has really formed the majority of the type of care delivered to the pediatric and adolescent population. I think in the interest of time, I'm going to skip over the next few slides, but you'll have these at your disposal. These really just describe the different aspects of acute and chronic illness care that's provided, and I want to move ahead and talk a little bit about well care, because that really is the core of primary adolescent health care. And what we see embedded there is both a public health agenda, so thinking about screening for common diseases and things that we have interventions for. Certainly the provision of immunizations is a shared agenda item between adolescent well care professionals and the public health professionals. But then there's that aspect that is the personal health agenda as well. So identifying the specific needs and concerns of the patient and family, and providing very tailored anticipatory guidance in the form of education and support to address those issues. And I want to give a shout out to the Bright Futures Guidelines for Health Supervision of Infants, Children, and Adolescents, because if you're looking for guidelines for adolescent care, this is for you. And in fact, we are delighted to say that the 4th edition of these guidelines was just released. We're proud that the 3 editors of the guidelines, Judy Shaw, Joe Hagan, and Paula Duncan, are all Vermont pediatricians. So we're pretty excited when there's any new development with Bright Futures. But those of you who are familiar with it know that it's organized by themes and visits. There is wonderful age-specific content, including that which is separated out for early adolescence, middle adolescence, and late adolescence, which takes you up to the age of 21 years. There's an accompanying tool and resource kit, some additional practice guides, just lots and lots of materials to support and drive how care should be provided. And a couple of things about the 4th edition that I think you'll be pleased to see. There's much more of a focus on addressing the social determinants of health in this new edition, as well as an increased focus on specific services for children and youth with special health care needs. So if you haven't pre-ordered your copy, do so now, and then really most importantly, I think about sharing it with your community partners with whom you're working to improve care delivery. So how are we doing? We've got a system that does generally provide first contact for adolescents. It's longitudinal, fairly comprehensive, more of a focus on acute illness and perhaps not quite as strong with chronic illness. But we certainly have room for improvement in care coordination, in our ties to community agencies and services, and in our accountability. And that's really that's the direction that we've been headed with these new models of care. So I'm going to pause here for just a minute. We want to do a check-in to see if anyone has chatted any questions. And I would love it if any brave participant, when you think about the system of care for adolescents and young adults in your community, are you seeing aspects that look the same as what I've been describing? Are you seeing innovations that make your systems locally look quite different? And have you, in your programs and activities, done any work that interfaces with these components of the healthcare system for adolescents and young adults that we've been talking about? So I'm going to stop for a moment and hope that Rena and Kristen have unmuted us appropriately. But we do have a question, a wonderful question. Who chooses the quality benchmarks? Fantastic question. So this is where I think you can really partner with the healthcare professionals in your states and communities on this topic. The way things work currently, there are national systems, such as some of you may have heard of HEDIS measures, the Health Effectiveness Data Information System, where national and federal entities have gotten together and said, we think, for example, that making sure that adolescents have received all of the immunizations recommended for them by a certain age is a quality measure that we should hold everyone who provides health care accountable for. But then when we begin to move from that federal perspective to state and even regional and community organizations, there are a myriad ways that these benchmarks are chosen. In adolescent health care and to some extent in young adult health care, there's general agreement. We sort of start with the evidence base and say we know immunizations are effective. We know that if we screen for chlamydia and we treat appropriately, that leads to better health outcomes. We know if we monitor blood pressure, weight, height, and body mass index, and we intervene when those things are going off track, that leads to better health outcomes. So we have general agreement on many of the benchmarks, but at the end of the day, a local or regional system can say to the health professionals in their community, we're going to hold you accountable for X, Y, and Z. And you may, as a health professional, agree with that. You may like it or you may not, but that's what you're held accountable for. So the bottom line is, if you as public health professionals interested in this topic can get together with your health care professional community and say what makes sense from both a population health perspective and the perspective of those of us who are delivering health care to individuals, and let's lobby our local accountable care organization to say we would like for the adolescent well care visit to be a quality benchmark, because we believe that if we improve our rate of adolescent well care visits, we will improve the screenings that go along with those and the referral and treatment, and ultimately will improve health outcomes. So, to summarize, there are national level and federal level agencies and organizations that identify benchmarks, but then when you get down to the provision of care in a community or a region, those benchmarks may look the same or they may be different, and you have the opportunity to influence that if you find out where those measurement discussions are happening and try to get yourselves to those tables and participate. I hope that answered your question. Any other comments on these questions? And we'll move along quickly because I do want to leave time at the end, so we can go fairly quickly through our next few slides. So I think at a big picture level, what we're really seeing in these new models is a shift, as I've mentioned, from this fee-for-service type of payment system to value-based payment. Some of you may have heard discussions about the triple aim, which comes from the Institute for Healthcare Improvement. This is really their framework and an approach to optimizing health system performance. So again, emphasis on healthcare as a system and emphasis on monitoring and measuring and improving performance. And really the key drivers that you'll see described in these frameworks are improving the patient experience of care, and that has to do both with quality of care, but patient satisfaction becomes very important. Improving the health of population, so that population level view as well, and still an emphasis or a focus on reducing the per capita cost of health care. I think people agree that we have an unsustainable acceleration in health care costs, and we must intervene because it's simply not sustainable. I'm going to skip over the next slide because, again, I think this is really somewhat of a recap. And just a few words about young adults, because you've heard me say that it's, first of all, a bit more difficult to identify a visible system of care, a devoted group of healthcare professionals that want to serve this population. And so what that has translated into, and particularly prior to the Affordable Care Act, we know from much research that young adults tend to have significantly lower rates of utilization of the healthcare system. They have the lowest rate of office-based utilization, and yet they have higher rates of emergency room visits, so increasing cost and increasing fragmentation of care, and really not leading to those attributes of a quality healthcare system that we talked about earlier, like comprehensive and coordinated and continuous and longitudinal over time. And if our young adults prior to the ACA were uninsured, they experienced very high out-of-pocket costs for the health care that they did seek. No question that the Affordable Care Act has had a positive impact on the provision of health care to young adults. They are receiving routine examinations at a higher rate, screenings like blood pressure and cholesterol, and even ancillary services like dental care have increased in the wake of the Affordable Care Act. We've seen increases in their full-year private insurance coverage, an overall decrease in the uninsured rate, and relatively stable rates of young adults with public insurance. So some of the themes that we've seen emerging, and I mentioned healthcare is local, so not only is measurement and benchmarking local, but really how your systems operate can very much, they can either mirror some of the national trends or they can look very different. So this is where, again, it pays to get in the game and participate with your community partners in trying to advance healthcare system reform for adolescents and young adults. We've talked about some of the changes in payment and the accountability for how care is delivered, the new practice structures. Haven't said much about health information technology. I'll show you a slide on that momentarily. And the practitioner mix is really this idea that we're seeing more and more systems evolve with a mix of care provided by teams, so physicians, nurse practitioners, physician assistants, but also increasing and more visible roles for other health professional staff in providing care. The community engagement is huge, and then addressing behavior change, which is such a big part of improving health outcomes, and particularly with the adolescent and young adult population. I want to skip ahead to the health information technology slide because this is another one when you think about how you can help influence improvement in care. Think about the systems that your healthcare professional partners are having to deal with in implementing electronic health records which are great in some aspects, but not particularly designed for pediatric or adolescent medicine, can certainly slow down the provision of care. Getting useful data for practice quality improvement or management purposes may or may not be easy. Patient portals are showing promise, but we have a long way to go before people are really using them actively at a high rate. For the adolescent and young adult population, I would say text reminders are showing great promise, and that's something to pay attention to, as well as the provision of information through mobile apps. And again, not great evidence yet, but showing promise. And telemedicine may become more visible and important in the future. So I'm going to skip ahead and end by talking a little bit about strategies, partners, and incentives. And in terms of strategies, one primary resource that I want to leave you with is a document from the Centers for Medicare and Medicaid Services called Paving the Road to Good Health, Strategies for Increasing Medicaid Adolescent Well Care Visits. And this is a really wonderful document. I hope you all have seen it, but if you haven't, I urge you to look it up, and the reference is there. And I've just broken out their high-level strategies and then some of the sort of subsystem improvements that we think have a pretty good evidence base for improving health care. And again, sadly, the focus here is, well, not sadly, but the focus here is primarily on adolescents, and we just don't have this level of maturity for strategies and incentives for the young adult population yet. But adopting the Bright Futures guidelines, and in particular aligning this with your state Medicaid policy, which is a role that you very much can play if you haven't already done that in your states. Incentivizing providers, and I'm going to show you some specific incentives in a moment, but not only the health professionals, but the adolescents and young adults themselves, and then parents. And this has a lot to do with being able to demonstrate the value of preventive services and the well care visit to those various aspects of the population, and helping to think about ways to motivate this group to make and keep their well care appointments. And certainly working to encourage the provision of teen-centered or adolescent and young adult-friendly care. There are some promising practices in this regard, but health professionals need help with developing their skills in this regard as well, and that may be a role that you can play in directing health professionals to adolescent and young adult-friendly materials. So incentives, a few more strategies here. Leveraging missed opportunities to increase well care visits, and so this is taking advantage of when and where AYAs show up for care, and even if things weren't scheduled as a well care visit, grabbing those opportunities on the spot to provide more comprehensive and preventive services. We talked about the use of social media to increase well care visits and the provision of health information. And then again, partnerships with key community stakeholders is huge. So incentives. I think what you see here are some of the primary incentives for health providers. And, you know, we may have little in the way of being able to influence payment reform, except that if we're paying attention and particularly thinking about measurement strategies and benchmarks, that may be a way that we can help. Supporting quality improvement activities, you know, providing data if that's needed to some of your local health professional entities and organizations, and thinking about the activities that you undertake and whether they might be able to help health professionals achieve satisfaction in meeting their regulatory and accreditation activities. So some of you may have heard of the National Center for Quality Assurance and the Patient-Centered Medical Home Initiative. This is a way that health care practices can get paid an enhanced reimbursement by meeting certain benchmarks, and some of the work that you do may be able to help them meet those benchmarks more readily and more easily. And then thinking about health professional board certification requirements and the activities that they need to conduct in order to meet those requirements, and whether any of the activities that you do with them might be able to support that as well. Finally, I think thinking about incentives from the perspective of multiple stakeholders. So what do the patients want? What do the health professionals want? And I'm going to skip to the next one in the interest of time, thinking about what payers and what state government and federal governments want out of our health system evolution. And think about how the work that you do might be able to contribute to these activities. So I'm going to stop there and ask again for questions and discussion, and would love to hear from folks if you can think of other incentives that maybe weren't on those slides, and I realize we went through them quickly. And also, we would love to hear from you, how are you thinking about and perhaps incorporating the use of incentives in your programs and activities, whether it's geared toward the health professional or toward the patients? Are you partnering with others in your state government to make incentives available for these kinds of activities? So we would love to hear about that. And I think I have one summary slide that hopefully will leave you with some food for thought about what the system may look like. Again, there are a lot of unknowns right now, and I think part of the leadership that you as folks interested in adolescent and young adult health can provide is truly in this time of flux to pay attention to the system around you and where you can influence that. So payment, how you might be able to support health professionals in their training, and think about how the primary care providers that you're partnering with will be encouraged to conduct their work in the future. All right, left a couple minutes for questions, and not seeing anything more in the chat box. Rena and Kristen, I don't know if the phone lines are open, but we're happy to take questions, and I'm also happy to hear from folks by email or by phone, and I think we have our contact information on an upcoming slide. But
all of the lines have been unmuted if you'd like to ask a question. And if there is anyone speaking and we cannot hear you, you may also unmute your line by pressing #6 if the unmute all function did not work.
Well, this is Kristen Teipel. I want to thank everyone. In regards to time, I want to honor everybody's time and thank you for being here today. Please mull through all the information you've received today. If you have questions, I do ask, Wendy, maybe you could move the slide forward one slide.
We are trying, Kristen, but, oh, there we go. There, so we have the upcoming webinars.
So
and then contact information perhaps on the next slide.
It'll be one more beyond that. So please send your questions to us. If you're doing something interesting or just something routine in the area of improving quality, you're working with health plans, you are dealing with incentives, you're aligning quality measures, you're bringing telemedicine into places where it maybe hadn't been before, or linking people, please drop us a line and let us know, because we'll share that through in the upcoming events. And as we move through the slide again, do look forward to 3 upcoming webinars. The next one will be Healthcare Quality 102 on the basics of quality improvement in clinics on March 29th. Then we're going to add in ones very specifically about an opportunity that's happening in Ohio with the American Academy of Pediatric chapter there. They have a Transforming Adolescent Care Learning Collaborative effort that we're going to highlight and explore. That'll be on April 10th. And then on April 20th, we'll have Healthcare 103. Digging into how partnerships happening at a state level really do influence the quality of care. So thank you again, really appreciate your time and effort, and we look forward to seeing you in future webinars and learning community events. Thanks.